Hello and welcome to session 3 of the second annual Completed Life Fall Conference. My name is Sarah Kiskadden-Bechtel and I'm the Program Director for the Completed Life Initiative, and I will be your host today. At the Completed Life Initiative, we promote self-determination and dignity at the end of life. If you are new to our event programming, please feel free to explore our video archives on our website after today's event at completedlife.org. Our second annual conference examines core elements of medical aid in dying. What happens after legalization of assisted dying? How has the legislative landscape in the United States shifted over the past 30 years? And where is it headed? What is the global significance of the Right to Die movement? Whether you are new to our Completed Life community or a returning attendee, we invite you to come prepared to ask lots of questions. These sessions are invaluable learning tools meant to empower you to have an informed conversation for yourself and with your loved ones about the question, what does it mean to live a completed life? Today's session 3 examines the existing barriers to access for diverse and underrepresented communities. Specifically, unwanted care and care that is not well considered is still the most prevalent assault on people's right to how their lives end. Conversely, those who have a lifetime of experiencing a stark inequity in healthcare coverage may prompt underserved populations to pursue the quote unquote do everything model of end of life healthcare. How do we balance the absence of a right to healthcare with avoiding the end of life conveyor belt? How would diverse communities wish to be approached and supported regarding their end of life experience? A little background on our speakers. I'm delighted to welcome Tracey A. Bush and Dr. Lonny Shavelson to our Completed Life stage today. Tracey is MSW, LCSW, and has been the practice leader and consultant for medical social work and the End of Life Option Act at Kaiser Permanente, Southern California since 2017. She served as Director of Medical Social Work at the KP Panorama City Medical Center for 11 years and worked as healthcare ombudsman and mediator in the Valley Surface area for Kaiser Permanente. Tracey received her Master of Social Work from Tulane University in New Orleans and holds social work clinical licenses in Louisiana and California. Her clinical interests and expertise are in pediatric and adolescent mental health and patient healthcare decision-making around terminal illness. She has over 30 years of management and clinical experience and has worked as a social work field instructor and taught residents, fellows, nursing students on various psychosocial topics in healthcare. Dr. Lonny Shavelson, MD, founded Bay Area End of Life Options in 2016, a practice dedicated to terminally ill patients who are considering aid in dying under California's End of Life Option Act. The practice closed to new patients in August of 2020 when Dr. Shavelson became chair of the American Clinicians Academy on Medical Aid in Dying, also known as ACA-MAID. He was also the lead organizer of the first National Clinicians Conference on Medical Aid in Dying, held at UC Berkeley in February of 2020. His present work focuses on advancing the clinical knowledge and practice of aid in dying, teaching, consulting with other clinicians about their patients, and advocating for best practices in medical aid in dying. Before establishing his aid in dying practice, Dr. Shavelson was an emergency department doctor for 29 years and then served 7 years as a primary care physician in a clinic for immigrants and refugees. Dr. Shavelson has been deeply interested in issues about end-of-life care for more than 25 years. He wrote the 1994 book, Chosen Death, was one of 5 authors of the 1997 proposed guidelines, Physician Hastened Death by the Bay Area Network of Ethics Committees, published by the Western Journal of Medicine in 1997. And he was also involved in the writing of amicus briefs for the Supreme Court when it considered the issue in 1996, a la Vaco v. Vaco. When California's End-of-Life Option Act went into effect in 2016, Dr. Shavelson opened his medical practice to improve patient access to aid in dying during the years it would take to implement the law. Before we begin, please be aware that you may input your questions into the chat feature located on the lower right-hand corner of your screen. We welcome your questions at any time throughout session 3, and later on, we will turn to your questions for an interactive Q&A with our esteemed panelists. Also, if you'd like assistance with closed captioning, you may toggle on the box located in the lower left-hand corner of your screen that provides captioning for the spoken words of our event today. Throughout today's event, feel free to tag us in your social media posts and tweets at Completed Life and hashtag Completed Life. And finally, the recording of today's event will be published after the conference concludes. All right, so welcome everyone and thank you for joining us. Let's begin with a short video that sets the stage for today's discussion. This video presents a woman named Kay Hudson. Kay is the sister of one of Dr. Shavelson's patients, named Stevie Hudson. As Stevie's physician, Dr. Shavelson entered into the midst of a family conflict of whether Stevie was going to take medications to die. So we're left wondering what's going to happen with Stevie's care.
I'm Kay Hudson. I'm the sister of Stevie Hudson. He died February the 1st, 2019. When I spoke to my brother about the aid in dying, I was shocked. We are Christians, and I know that, my brother had a relationship with God, and we were brought up, we were raised to, that suicide is a sin. He said, I will never find an area in the Bible where it said men should live by machine. I can only speak for my family as African Americans. It was natural for us to take care of our family members. It never was a burden. It never felt like a burden. Even back from during times of slavery, when the African American structure of the family was broken, we had to look after each other then. And that's how it's been passed down. I never once got tired of taking care of him. But he felt as though the health care gave up on him. Yes, I did believe that my brother had inferior medical care due to his ethnicity, being an African American. He felt like they didn't want to care for him anymore. And then here I am trying to tell my brother, hey, give this a shot. I think what was behind his decision to end his life was he felt as though they kind of like threw their hands up. We had a home health agency, better LVNs that did ventilator care, but they were sent into the white areas. We had one uh, white LVN that came. She went back to that home health and said she was not comfortable in the home. Why you just don't tell the truth? You're not comfortable working with an African American. Even trying to advocate for my brother, I was seen as being aggressive. I was viewed as being angry. And they never really got to know, and during that whole time that I'm advocating for my brother, I'm also in grad school as a social worker. Didn't nobody really know who he was, who we were as a family, what was going on. That's where a lot of the, distrust just is distrust everywhere. I knew no, he was tired of being on the ventilator. He said, I'm done. And he told me no more talking. Although it was Stevie's decision, he felt like there was nothing else left. I would like for all you people at this conference to know, I think it's up to you guys to show that we should or we can trust you.
Thank you so much,
Okay.
Sarah, for that introduction. And to our audience members, we really appreciate you being here today and certainly want to honor any veterans who might be in our audience as well. So I was thinking about today's topic and whether or not the right to die is being held hostage, so to speak, by the right to health care for patients. And initially, I answered that question and thought, well, yes, of course. That's a simple question, a simple answer. Okay, our conference is done for today. I don't need to say anything more. But viewing the video that was so generously recorded by Miss Kay Hudson about her brother really inspired me to pause and think about the question on a deeper level. So initially thinking about whether medical aid in dying really should be presented in this same context, I think artificially separates us in a way from the rest of the culture of medicine and the culture of healthcare. I don't think that we can separate ourselves, even though we account for just a tiny sliver in the healthcare system. We can't posit or assume that we are any different in a cultural perspective than the rest of healthcare. We exist within this system as clinicians, as physicians. So thinking about this question, I think that medical aid in dying as a concept, as a part of healthcare, have to really take some accountability and some responsibility for the experiences patients have before they get to us. So we know that healthcare, just like medical aid and dying care, just like the rest of healthcare, is political, it's economic, it's cultural. If we don't agree, I can say one word that will, I think, convince you. If I say the word abortion, which has nothing to do with medical aid and dying, immediately we think about healthcare, we think about our religious beliefs, we think about our culture, we think about politics. They all intersect within the construct of healthcare, in the construct of medical aid and dying. So our history really within this field is one that includes ideas such as death with dignity or a good death. And I think that from a cultural perspective, when we think about the diversity of our patient populations, these very assumptions, I think, don't acknowledge the experience of the other, the people within our practices who don't possess power, who don't have the opportunity for dignity within the healthcare system before they are transitioned to us for care. So I can understand and acknowledge that on many levels, there can be a bit of anxiety, paranoia, aggression from these populations who, rightfully so, I would argue that at this point in my life, all of a sudden, you are wanting to have me be included in your healthcare and in your healthcare system. And I think patients have the right to ask, where was this wonderful system when I was trying to get a diagnosis? Where was this system when I was trying to access specialty care? Where was this system when I was trying to get adequate pain control? So I think while we may not be individually or personally responsible, this is the culture in which medical aid and dying exists. So I think we have to accept and recognize and honor the fact that patients' experiences are skewed and shaped and colored by their lack of access to the rest of the medical system in which we exist. So I would argue that MAID certainly is being held hostage because patients are being held hostage within the system. Their individual experiences, I think, reflect the reality of the system in which they exist, in which we all try to exist. So I think our offerings of this type of care in some ways exists in the secular world of healthcare, but we know that patients don't necessarily live in this secular world, and they make their healthcare decisions based on their world, their culture, their religion, and then their experiences of us, because I don't think they see us as any different than other members of the healthcare team that they've had experiences with before we arrive on the scene. So I think about patients who are disenfranchised, patients of color, people who may not have insurance, so the uninsured or the underinsured patients, and what their experience is of the healthcare system and what impact that has on medical aid and dying. So those would be my opening comments. Lonny, I understand that this was your patient and a family that you worked with, so I would be curious to hear some of your thoughts as well about those ideas that I've expressed. And I think that you also have some information about these various patient populations and their thoughts about medical aid and dying, whether they believe in it, whether they would participate in it.
Yeah. First, thanks, Tracey. I'm happy to see you again. I always learn so much when I listen to you, so it's great fun. Let me, if I may, try to back off and feed off of what you just said, Tracey, and continue that perspective. I'm going to share my screen with any IT luck. Share. And now I'm going to try and show you a couple of slides. I promise I'm not going to be as slide heavy as I usually am on this particular day, but let's go. So just a little bit of perspective. These days, we are, because of COVID, so acutely aware, or at least I hope we are, of how much everything in medicine now is divided based on economics, socioeconomics, ethnicity, culture, where you live, how you live, all of that, but especially the information that we've been getting over the last 2 years, certainly during the pandemic, and on before that, just seeing the beginning of an understanding of, as the center of this slide shows, how we fail Black patients in pain, the struggle for equality in healthcare, the race discrimination in cardiovascular disease. It goes on and on and on. And so that when a patient from from any group comes to us, they have already existed in a healthcare system that is filled with gross inequalities. We know this now. I think there's some progress being made, but when I see a patient at the end of their life, whether it's specifically focused on aid or dying or not, this is the baggage that we all bring. My baggage of a history and the baggage of the communities I'm working with. And so to change this a little bit around, and let's look at some data, and my apologies for how busy this graph is, I'll talk you through it. This is a California Healthcare Foundation survey in 2019 about various healthcare issues, including end-of-life issues and including medical aid and dying. And no surprise, if you look here, I think you can see my pointer, when asked about barriers to accessing healthcare in general by race, ethnicity, and income, I've kind of ignored income in my comments here, but interestingly, the biggest category, I think, is patients who actually said they were denied health services for a variety of reasons, mostly ethnic and cultural reasons. And of those, of course, African Americans, Blacks, are listed here. 43% of African American patients in this survey in California thought that they had been denied health services based on their ethnicity, based on, as Kay said, is because I'm Black, I'm African American. We didn't get good health care like everybody else does. But here's what's even more fascinating as we bring it into my field, which is medical aid and dying. If you go down to this little yellow, and we look at the same kind of groups, and we ask the question, do you support the End of Life Option Act, the name of the act in California, fundamentally saying, how do you feel about medical aid and dying? And I thought that that would skew tremendously different based on ethnicity. This poll, by the way, asked around the country, tends to hang out about 70% or more of the population of the United States is in favor or supports the concept of medical aid and dying. But here what we look at, and if you look at the skew here, it's not very much. 76% of Asian Pacific Islanders, 70% of African Americans say they support the concept of medical aid and dying or the End of Life Option Act. Latinos come in at 68%, whites highest, but you know, it doesn't show a widespread. So the curious thing to me was, how is this if 43% of African Americans feel like they're just not getting good health care, and yet 70%, contrary to what we had thought before, support the concept of medical aid and dying? So let's flip these graphs around a little bit. On the left now, you see the same one I just showed you in the lower right with this 70%. So if 70% of African Americans support the End of Life Option Act, over here we have the 2020 Health Department data of the usage of the End of Life Option Act. And if you look right there, it's 0.9% of all aid and dying cases in California were African Americans, less than 1% compared to 70% who say that they actually support the concept. So this kind of changed my mind when I started looking at this, of the idea of, everybody's been saying, you know, if only we could get these other communities, not my term, other communities to understand how good our medical aid and dying is, how it's an act of dignity, the Death with Dignity Act and all that. If only they understood, then they participate. We have an outreach problem to make them understand. And this puts the lie to that. They do understand. 70% say that, yeah, we believe in it. We think it's okay, but only 0.9% actually participate. And what that means to me is that the problem isn't one of saying, believe in what we're doing. The problem is one of saying, trust us. Because when push comes to shove, they're saying, I don't trust the medical system. And I'm not trusting you any more than that. And I'm not about to have you invited into my house, as I'll bring up with what happened with Kay Hudson when I walked into their house. I'm not inviting you into my house to help you, the term will be kill my brother, although I fundamentally believe in the general idea. So the gap is not that we have a problem of communicating with them. I think the gap is that we need to understand much, much better where they're coming from. They, in this case, minority, ethnic minority, different cultural communities, that we have to really work a lot harder to fix our problem, that we're reaching them, but they're not trusting us. So to move on, I was called by Stevie Hudson's attendant. Our practice, it was actually Thalia DeWolf, the nurse in our practice, and me. We were called by Stevie Hudson's attendant without his family knowing it to ask for help with aid and dying. He actually wanted us to sneak into his house and do it surreptitiously because he was so in conflict with what his family thought about the idea. And so you can imagine what this was. We have Stevie Hudson, the ALS patient on a ventilator, now deciding that he's ready to die and wants help with medical aid and dying, living in a family home where no one else in the family agreed. And let me just briefly paint a picture of how wonderful Stevie Hudson's care was. For those in the medical field, you understand how complicated it is to keep somebody at home on a ventilator. I'm not talking about ventilatory assistance or BiPAP. The dude's on a ventilator, tracheostomy, the whole thing. And they have taken care of him for the last, I think it was 2 to 3 years before we met him at home on a ventilator. He had no skin breakdown. He was well nourished. His skin was oiled every day. He had visitors. He had a computer system for communication. I can't tell you how good a care Stevie was receiving from his family and participating community members. And into that scene in a predominantly African-American community, Stevie calls us, and Thalia and I show up at the house, two white people coming in, telling them Stevie wants to die and we're going to help him die. So here's what then came into play with this family. Everything, for those of you who think we're talking about a binary decision, do African Americans believe in aid in dying or participate in aid in dying or not? This is so complex. First of all, the first thing that happened were religious beliefs were brought up. And this was all open conversation between Stevie, the family, and us. Sometimes difficult conversations, sometimes loving. Stevie was, and admitted readily, that he had a relationship with God, as did his family. The family was adamant that suicide in their belief system is a sin, that only God will make the decision of when we die. And to which Stevie would say, there's nothing in the Bible that says man must live by machines. And so we were in the middle of this sort of theological argument within the family. And again, we are outsiders, and they are feeling obliged to have to talk to us because we hold the key to that one aspect of Stevie's self-care. Cultural concerns. As Kay said, families and communities, and she was pointing out, since the Civil War and before, had to provide healthcare to their loved ones because nobody else was doing it. And so that tradition carries on, and it may seem like 150 or more years, but that tradition holds true. And I'll explain a little bit more about that as well. When we come in and we say that we're going to help you with aid in dying, we are almost saying your system has failed. And I'll always say that, for example, to segue for a second, when I talk to my palliative care colleagues, I will always say, don't think of aid in dying as a failure of palliative care. That's not what's happening. But when I walked into this family, it was clear that they thought that my message to them was, you have now failed in what you're doing. Stevie's ready to die. He and we are rejecting your family and your community's method of caring for people, and we're coming in to take over and now help him die. And that was a terrible, terrible message, whether intended or not. I knew that's what they were hearing, and that we're saying, we've given up on him. We've abandoned him. There's nothing more to be offered because we can't treat his ALS. We have nothing else to offer. So they see us as abandoning the patient because we didn't say, what we can offer is your continued wonderful care. You as a family and community, and I didn't say this often enough, and I should have said it more. You as a family and community have shown me the most amazing way to take care of an ALS patient that I've ever seen. By rotating care, by love, by every possible skincare you could do, by learning about ventilators. They taught us about the ventilator. We did not teach them. So healthcare providers, we pretty much ignored the wider family concerned. And I kept on saying to them that I understand your feelings, but in the end, the patient gets to do what he wants. He has the right to an autonomous decision, without me also acknowledging that the community has the right to an autonomous decision as well, and to respect that as part of the process. Along the way, of course, stereotyping. Kay Hudson was seen as repeatedly an angry woman. No one of all the healthcare providers I spoke to actually knew that she was a fairly sophisticated social worker. And so she was seen as just another interference, rather than the best healthcare that Stevie had ever seen was mostly organized by and provided by Kay. And then we put the bigger context we all walked into. So all of this is happening in that room where Thalia and I are sitting, two white people in a room of black people, trying to have a conversation about aid in dying. And in that room was Tuskegee of 1971 in the experimentation with not treating syphilis in African American men. Katrina in 2005 with literally with acceptable or non-acceptable euthanasia that was going on in an African American community where they couldn't provide the needed health care during a time of the flooding. And let me make a direct line to that. In 1997, when aid in dying started in Oregon, clinically started, to the present day today, is the feeling is you have not offered my brother Stevie good disease care along the way, and here you are finally saying you're going to offer him a good death. And the irony, and if you don't think there's a direct line between that and Tuskegee and Katrina, pay more attention, because it was in the room with us. It was brought up specifically. It's not some broad historical perspective. It's a present day problem, as we know how you give us disease care, and it's not good, but you're going to talk to us about a good death now. Finally, the health disparities in the present, unequal quality of healthcare due to being Black. You saw that 43% number. That's probably just a lot of people who are talking to, being polite to people who do polls. I think that number is actually quite higher, of people who felt like they did not get the same quality of healthcare due to being Black. So, wrong slide. Back to this again. I'm going to get out of share slide for a second and just chat. So, you begin to understand a bit more of, excuse me for a second while I do something technical. That, stop sharing my screen, stop sharing, and I'm back as being a human being instead of a slide. You know, I really want to emphasize the fact that there is a problem of respect going on. And I hear from people in my aid and dying community about how this low participation on the part of African Americans and Latinos, brown and Black people, is something it's a problem we need to fix. And I'm going to even debate two words, problem and fix. Is it a problem? Why have we decided that the low participation of African Americans in medical aid and dying is a problem? They have a community that works with their terminally ill patients in a highly sophisticated, highly effective way, and it doesn't use hospice as much as other communities, and it certainly doesn't use medical aid and dying as much as other communities. But is that bad? And maybe, I'm not saying it's not. We know that the community knows about medical aid and dying. 70% say they're in favor of it, and yet we have somehow decided it is a problem because they don't participate in medical aid and dying, rather than the problem may be that we are not showing them enough respect for how good their care for terminally ill patients is without our help with medical aid and dying. And then you throw in the religious, the cultural, the historical things. And I think the thing is that if we want to fix the problem, a very paternalistic comment, but if we want to fix this problem and really reach out to that community, the first way we do it is we stop talking about medical aid and dying, and we start talking about really improving medical care and terminal care for terminally ill patients, and really showing how much we respect how well a job people like Kate did with her brother and all in that community. They have a community feeling of taking care of their own patients. And I love that, and we need to respect that. And then along the way, if they're getting good care, they're probably going to have a different attitude about medical aid and dying, just like all the other folks who get good medical care. So I think we have a problem. And the problem is not that African Americans don't participate enough in medical aid and dying. The problem is that we don't look at what they're doing that's good in their community and acknowledge it. And therefore, they might see that respect we have and then bring us in a little bit more. So that's my end of that part.
Thank you, Lonny. And I'd like to, if I may, Sarah, I'd like to piggyback a little bit on some of your comments, Lonny. You know, is this a problem? Because this is a question I face all the time as the administrator overseeing a medical aid and dying program. In some sense, I would argue the lack of participation is a problem. However, I would argue that it's not a problem to be borne by the patient or to be resolved or solved by the patient. It's our problem. It's a systems problem, right? And so I would think that one of the issues is, um, of course, access, utilization, but I often make this argument, how is it that we invite these communities to participate in medical aid in dying? Clearly, if 70% are aware of it, but less than 1% are taking advantage of it, there's a disconnect. And I think the disconnect and the responsibility lies with us in the field to think about then what is happening here. People believe in it. Clearly, they're dying, either from natural causes or maybe from lack of access to care earlier. Nevertheless, there are terminally ill patients in these communities, and I would argue the issue is with our offering. How is it that we approach patients? How is it that these patients even get to us? Usually it's someone saying, there's nothing more we can do. They're throwing up their hands, and then they call you, Lonny, or me, or one of my social workers and say, okay, now you can talk to these people. Well, that messaging and sort of that invitation for us to come to the table, I would argue, is really conveying to the patient that there's no hope. We're done. There's nothing else we can offer to you. And there is hope. The hope may not be in a cure, but the hope may be in good care that you're going to have. The hope can be in, sort of having a great ending with your family, saying what needs to be said, taking care of your business, and really the hope of maintaining that the vision. If this is a very religious community, or these are very religious communities, Black and brown communities that I'm talking about now, really saying to them, accepting of this kind of care does not deny the fact that your God is still in control, and the fact that there could be a miracle. It may not be the miracle of a cure, but it's, the miracle of, whatever you want to see at the end of your life, and really asking patients what that is. I think we as medical providers really talk about the good death, and some patients think, well, no death is good. And we talk about alleviation of suffering, and some of these communities think, well, we've been suffering for generations, and there's honor in suffering, and it's not necessarily a terrible thing. So I think in the way we offer medical aid in dying is one of the barriers to patients accepting this as an option for themselves, and matching that 70%. Yes, we believe this is a good thing and it should be offered, with the 1%, but no, I'm not going to accept this from you.
Thank you, Tracey. Just to inquire further, I'm wondering, with intrinsically different value systems and issues with trusting the healthcare system in Black and brown communities, how does this interplay with deeper barriers to access aid in dying?
Well, I think about the Death with Dignity movement. One of my concerns about that movement, and I'm not saying it's terrible, because obviously MAID is a part of that, and sort of one of the end results, that this has become legal in several states here in the United States. But my question is, has that movement really opened its arms and invited these disenfranchised communities to become a part of it? I think one of our challenges is that the movement itself has become stagnant in some ways, and really has sort of seen the end point is the passing of the legislation. And I would argue the way some of the legislation is written will inherently disenfranchise some communities. So in California, where I practice, physicians must have these conversations individually with patients. It's the way the law is written, so no one's going to break the law to help a patient access this. Yet we know with these Black and Brown communities, the family needs to be in the room. And so I think that we need to think about in the room in a different way while having that parallel process of still advocating. Perhaps the law can be a little bit more flexible and reflect the communities for who they are written. California certainly is not 1% Black, right? It's certainly not 84% white, as the medical aid and dying statistics would have you believe. We have a skew in that population. So I think, inviting the family in the room, not literally, because I realize that would be illegal in some jurisdictions, but when we're talking to the family or the patient, for many of these patients, this decision is not an individual decision. I am not making this decision for Tracey. I'm making this decision in the context of the people that I love, my family. What are they going to think? How are they going to feel? And do you, as a provider, understand that? And are you asking me about it? Are you honoring that? Are you asking me about my religious beliefs, my church, my pastor, my priest, and bringing them into the room in a figurative way and really honoring the patient's culture? So I think even with the passage of this legislation, I think we have a lot to do from a programmatic perspective. And I think our lawmakers and advocates have some work to do as well, even when the legislation is passed.
Tracey, it's a really good point you're making about bringing back to the law itself. I love that law. I respect it. It allows me to practice medicine. It allows me to do medical aid and dying. And yet, there are so many problems, cultural, spiritual, whatever. None of that is in there. There's nothing in the law. And that really acknowledges these differences. Of course, we're trained all to be culturally appropriate or whatever else we do. But just think about the law. The law is built on probably 80% of that law is safeguarding patients from abuse, right? Easily. And so we have all of these abuse preventions that we all follow carefully because we don't want to be accused of felony murder. And so much of that is avoiding coercion from family members. Now, and it's probably not a bad thing. We have to, at some point in time, talk to the patient alone. But the emphasis on avoiding coercion, as if there's a whole community of people out there who want to steal dad's home and get him out of the way as soon as they possibly can. And it's insulting to a certain extent. And yes, we must provide that safeguard, but that should be a brief, the understanding of clinical medicine, right? I know whether there's coercion probably within about 3 seconds of walking into a room. You're a social worker, right? You don't need to go in there and say, has anybody said to the patient, is anybody putting pressure on you? You get the sense of the family pretty quickly, and then you get a sense of how to navigate that family. And for some families, honestly, it's insulting but necessary to say, I now must speak to the patient alone to be sure about safety. I don't have any problem with that. But I think the general sense of the law is one of preventing, by putting up so many barriers to care, signed witness statements, the 15-day waiting periods, et cetera, the law is filled with barriers. And every one of those barriers falls harder on poorer ethnic communities who have less access to health care and less experience at fighting for themselves to get better care. And so a large part of that, the way the law is written, and I think it's being remedied as we see changes to the law, both through new legislation and through lawsuits, we're starting to sort of chip away at that. The law's goal is almost not to provide medical aid and dying, it's to prevent abuses of medical aid and dying. Because if you really want to sit down and read that law for a long time, as I have done many times, it's really about protecting patients from abuse. And that's just not been demonstrated to be that much of a problem. And I'm not arguing to not protect the patients from abuse. But if I walk into a family and community, and my main goal is to look around and say, anybody here trying to coerce the patient into dying, that's a mistaken attitude.
Right. Yet one thing we can't legislate, Lonnie, which is the responsibility that healthcare providers have in walking in the room and realizing that while we have legal and ethical and moral responsibilities as healthcare providers, we also have a humanistic responsibility to the patient and to the family to understand them and where they come from. And I think one of the challenges when we think about patient access to medical aid in dying, and is it really being held hostage by patients' lack of access to healthcare? It really is. So if these families are not, if patients aren't receiving good medical care up front, if they're not necessarily engaged with hospice or palliative care services, then how do they access medical aid in dying? Because it usually would be that hospice team or the palliative care team making that referral and connecting them with our services, with medical aid and dying services. So I think that we have some responsibility in the way that we receive these referrals and the way that we walk into the room when we're approaching patients and families, and still doing that in a way that respects the law. So even in the way that our literature or patient pamphlets are 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 written out, who they're handed out to, and that sort of thing. So those are just some initial thoughts that I would have.
Yeah, the stigma. Let me paint two brief pictures, if I may. One, not to pick on Kaiser. I think Kaiser has a wonderful, wonderful aid and dying system. But your pamphlets, not yours. I know this for Northern California. Your pamphlets are under lock and key in the waiting rooms, because you're not supposed to let people somehow get this information without permission and all that. So this thing of we are some weird separate thing that you have to prevent people from knowing so that we're not promulgating aid and dying leads to, and that and all the hoops that people have to jump through is what I meant to say. So when I've attended about 240 at the bedside of these deaths now, in the room with the family on the aid and dying day. And here's what it looks like when I walk in. I go and I hug the patient, and I turn around, and there's usually 8 to 12 people standing in a circle, maybe 5 to 10 feet away, as if there's something weird and formal that's going to happen. And they've been through so many formalities and all that, they're afraid that they're going to do something wrong. They signed their witness statements. We just signed the final attestation. They've had to get the pamphlets out from under lock and key to get information. And all this stuff has created such fear of a process that is a kind and loving process. And the first thing I have to do when I walk into the room is say to everybody, come on in. You don't have to stand away. This is your loved one. This is the crucial day of their dying. Come on in and love them. Don't let me get in your way in any way, shape, or form. Let's move the bed out. It's up against the wall. Let's put it in the center of the room. Come on in, pull up chairs. Don't be standing around, and chill out. And so I think that that's really important to understand, as the barriers go to the very moment of taking the medications. And those barriers are real, and we ourselves in the process have stigmatized medical aid and dying as if it's not already stigmatized enough by other routes.
And the thing
So
is, Lonnie, oh, sorry, Sarah. I guess what I was going to say is healthcare is formal, right? The exam room is formal. The physician walks in and they take the seat. So family members are getting up and getting out of the way, and this is how healthcare is. So this is my argument that I think we have to somehow change our healthcare world so that when patients have this experience at the end of life or using medical aid and dying, it's not so different than the rest of healthcare. But that's how healthcare is. The physician walks in, everyone steps back. You're in charge. We don't say anything. It is a formal process. Physicians don't hug their patients. So this is very foreign compared to how people usually experience healthcare. Sorry, Sarah.
No worries at all. Thank you, Tracy. So what Lonnie was just speaking to, it echoes what Thalia DeWolf put into the chat. She wrote a comment saying, I believe there is no legal requirement to let terminally ill patients and their families know that medical aid in dying is an option. And as you mentioned, there's still so much stigma about aid in dying. I'm wondering, how does that affect the access, the comfort level, the family grieving after the patient dies? What are your thoughts, Tracy?
I think my initial thought is that's right. There's nothing that says patients and families can't know this exists. But my question is, who's going to tell them? So I think what I've experienced being a medical social worker is many times the teams, so I'm going to pick on oncology for a second. So sorry, oncologists in the audience. But my fear always is when I'm dealing with an oncology patient is the oncologist will wait until the 11th hour and the 59th minute to tell the patient, I don't have other curative treatment options available to you. I think they see their role, and they're physicians, so their job is to cure illness as much as possible. But I think in the enthusiasm of getting that done, there are not these other conversations that are happening all along the way, not educating patients from the beginning. If you get to this point, and we're not saying you're going to get to this point, but if you get to this point, we have hospice available, we have palliative care available, we have medical aid in dying available to you. And I think sometimes the fear is, and this is the culture of oncology, if we bring this up, patients are going to think we're saying they're going to die, or they're going to think we're giving up on them. And that's not it. You're just really sort of laying out what future options could be and what their lives look like. So my argument is, no, there's nothing saying people can't know about it, but who is going to tell them? And if they're not getting good care before this, if they're not even able to access the care they feel they need, and I'm not saying patients aren't necessarily getting good care, but the surveys say patients feel they're being discriminated against because of their race. Is that reality? I would argue it doesn't matter if it's reality, it's their reality. So if it's their reality, it's reality. And so this is the world that we live in. And so, yeah, they're finding all of this out maybe at the point of being diagnosed. And so I would be a little paranoid too. Like, why do you want to refer me to hospice? You haven't even talked to me about chemotherapy.
I think, Tracey, can I prompt you to tell the story about the family who, you were talking about Pulse, I believe, and about how there was one family who was told that this patient's ready for hospice, there's nothing else to be done, and they were resistant because apparently the patient wanted to sort of fly home and say goodbye to other members. And I'll stop there because it's your story, but I think it's a very important one.
Right. It's just a story about how misunderstandings, I think, happen in healthcare. And so, when you have patients in the hospital and different teams are going in, the residents are going in, the fellows are going in, the attendings going in, and everyone's trying to convince the patient, you need to be a DNR, you need to accept hospice services. There's nothing else we can do for you. And that's, I think, is always the wrong message, because there's always something to be done, even if it's not a cure. No one really took the time to understand from that patient's perspective what he really wanted to do. He wasn't not understanding that his prognosis wasn't good. It's not that he didn't understand there was a terminal diagnosis. It's not that he didn't understand his time was limited, but what he really wanted to achieve was to go back to Louisiana, have one last visit with his family, and die amongst his family. And was the pulse form that important? No, it wasn't. What was really important was that patient's story and what he wanted to accomplish. And that was his hope and his miracle. It wasn't a cure. He wasn't naive that there's a cure for this terrible illness that I have, but the hope in seeing my family again, hugging them and dying amongst them, really can't be reflected on the pulse form. Yet, time after time, nurse goes in the room, physicians go in the room, even us, social workers go in the room. Maybe finally when the chaplain gets in the room, they get to the real crux of it. What is it you would like what would you like to see for your future? And if we just ask that question and stop talking, then we can understand. But we're trying to convince, because I think we do have this paternalistic approach to medicine and we know everything. And when people don't agree with us, it's because clearly they're just not educated. And I say that, facetiously, but
Yeah, thanks, Tracey. Let me just create another couple of quick scenes about this stigma. So everything goes on and we get to the time where the patient is making a decision about medical aid in dying. They've somehow jumped through all these various hoops and we finally agreed to it. And so two recent scenes. One is a common scene, which is the patient is in hospice, as we love to have all of our patients in hospice. And in a given week, the patient is visited by the social worker, the chaplain, the nurse, then the LVN, sometimes the doctor. And because the patient is a patient who's considering medical aid and dying, or is even signed up and ready and qualified for medical aid and dying and thinking about a date, everybody walks into that room with this interestingly phrased question: are you sure you want to do that? And so 4 times, 5 times a week, the first thing the people come into the room: are you sure you want to do that? The social worker says. Are you sure you want to do that? The chaplain says. And after a while, this patient's pretty convinced that they don't really think I should be doing this. And the family is pretty convinced, what's wrong here? I mean, nobody, when the patient says, I really don't want a lot more morphine, or when the patient earlier had said to his oncologist, I don't really want any more chemotherapy, they didn't have meetings with 7 people asking them, are you sure? There's a conversation, then you believe what the patient has to say. And so we have had to request organizations to designate the one "are you sure" person. And everybody else shut up, because you're getting in the way and you're really frightening the patient. Now, yes, the "are you sure" question is valid, but to give you an idea. And so the second thing that happened just a few weeks ago was, and I heard this story, I wasn't in it, was a patient who was considering medical aid and dying, and in a hospice. And what they did was they set up a telemedicine discussion to talk to the patient about it. So what happened was we had a patient on telemedicine and 7 members of the hospice team: the social worker, the doctor, the chaplain, I forget who else was even there. Talk about intimidating. All there to say, and they opened the conversation, I was told, we're here to evaluate your decision about medical aid and dying. What is this, a trial? They had 7 people with this poor man who's close to death having to fight for his right to have medical aid and dying. And so that, to me, I mean, when I heard that, I said, that's patient abuse. That's not good clinical care and doing safeguards. That's abuse. And so this part of stigma of still seeing aid in dying is something special that we have to be afraid of. And that's where what you said, Tracey, the law comes in, is that we're so used to thinking about safeguard, safeguard, safeguard. Make sure nothing goes wrong. Make sure it's really what they want, that we forget that they have the right to make a decision without having to prove it to 9 people in the room.
But they don't, Lonnie. That's my argument. This is healthcare, right? If I have an early stage, breast cancer or something, and the oncology team really thinks you've got like a 99% chance at a cure, and if I said, but I don't want chemotherapy, it would be that same parade of people. You see, we can't exist outside the culture of healthcare. This is the culture of healthcare. Everyone would question that decision. Any decision, let me just put it this way, any decision patients make that is contrary to what the medical team thinks the decision should be will be questioned 1,000 times. And I don't think, unfortunately, medical aid in dying patients don't have the time for the arguments. Maybe other patients do, but I think other patients go through these same routines and arguing and cajoling and convincing, or whatever we want to call it, paternalistic attitudes. Because I think the bottom line comes to trust. Patients don't trust us, but you know what? We don't trust patients. That's really what it comes down to. So if we're walking in the room and we don't trust the patient because we know better, then why should they trust us? That would be my question. I wouldn't trust me either.
Yeah, I mean, what you said that was key just now was the term contrary to the prevailing opinion of the medical establishment. Stopping chemotherapy or not wanting chemotherapy is kind of not what we like people to do. And in the same sense, I would like to see a change clinically that end-of-life care providers in general are feeling more comfortable about the fact that medical aid in dying is an acceptable part of people's choices. Because if we don't trust the patient to be making that good decision because we are actually uncomfortable with the process ourselves, now we're projecting that discomfort on the patient. And I think we have a long ways to go to get our colleagues in this field, myself included, to not think of medical aid in dying. It's just such a weird, exceptional thing that we still have to protect against it unless it's the last resort. In fact, it's not the last resort. It's often the chosen resort. But then we feel like we have to make everybody prove it if they choose it. And that's in the law, that's in the amount of signing that they have to do. It's in the consulting physician, the psychiatric evaluation. Just pile it on until the patient feels like, damn, I'm doing something wrong. I better not do this. And that especially, by the way, just to bring us back to our theme of the day, is that especially falls on the ears harder of people who are disempowered, who are not used to fighting for their own in the medical system. And that, I think, has a lot to do with the lower percentage of ethnic minority communities participating in medical aid in dying, is we push them away even if they're interested, because we make them feel like they got a fight on their hands and they don't want to have to fight for that.
Because they're aggressive, like Miss Kay Hudson.
Yeah,
Exactly when
right.
she's advocating.
Exactly right. And Kay, yeah.
Thank you both. So let's talk about some other potential barriers to aid in dying care. Lonny, I was wondering, can you elaborate a bit about the role of hospice?
Sure. There's a very interesting thing in the history of aid in dying that we have, and I know where it began because there was an oppositional force. If we travel back to like 1990 or so, when aid in dying was being considered and everybody was talking about it, it was a philosophical debate. There wasn't a clinical debate because there was no clinical practice back then. It was before the legalization. And hospices were not only at that point in time uncomfortable with the idea, as many people were, it was new, they'd never seen it happen, but they were in direct opposition, as were most of the medical societies, et cetera, et cetera. And for very good reasons, I think, they developed this thing of what I used to call hospice versus hemlock. Hemlock being the aid in dying people, hospices being and then I like to be alliterative, so I call it hospices and hemlock. And there was some reality to that. And my position back in 1994, when I wrote the book, A Chosen Death, was hospices and hemlock was something we needed to bring together. They are not oppositional forces. We're all into the idea of providing the best death possible for patients who are terminally ill. Notice that I studiously avoid the term death with dignity. We can talk a little bit more about that. But in general, our goal in the medical aid and dying community and hospices are the same. And we in these days, now that things have moved on, have really come together. And the myth of the hospices being the opposition and the aid and dying folks being the death with dignity people is just that. It's a myth. It's a myth these days. I work very closely. Hospices are my friends, our friends in the medical aid and dying community. They're our friends, our colleagues. We share goals together. I almost never anymore see hospices be oppositional. Even the Catholic hospice in my community that can't participate in anything at all for fear of lightning strikes, there is still, they talk to their patients about their thoughts about medical aid and dying if the patient brings it up. They refer patients to my practice or to the academy. They're actively participating. They're not bowing out. In fact, this particular hospice allows their nurses to be in the room on a medical aid and dying day to not abandon their patients. And to give you a quick summary of how this worked was in 2016 when I opened up my practice and when the law became effective in California. And looking around at the hospices in my community, let's just say there were 100 for a convenient number, and that's probably about right. Maybe 10 of those hospices knew anything about or wanted anything to do with, so that's 10% of those hospices would actually talk to patients about it. The others would say, we don't do that. Here's Lonny Shavelson, go talk to him about it, and they would bow out. Within a year, that number rose to about 50%. Within another year, about 80% of the hospices in my community had consulting physicians. So if the idea that you need 2 doctors to approve medical aid and dying or to qualify somebody, they were providing consulting physicians. Their nurses were able to be there on the day of aid and dying. They talked about it. We had very, very, very close relationships about how the palliative care at the end of life changes for patients who are interested in medical aid and dying. And the relationship between hospice and medical aid and dying community, both two communities, is very, very, very tight and cooperative right now. There are rare exceptions. I have heard of one recently of a hospice that discharged a patient because the patient said they wanted medical aid and dying, and that patient got kicked out of the hospice. I think that's reason to bring that hospice up to the medical board for abandoning a patient. But those are really rare exceptions. On a philosophical and pragmatic level, hospices are our medical aid and dying friends. They might have some bureaucratic obstructions, as does so much about medical aid and dying. I think there's some policies that need some tweaking, such as asking the nurses to leave the room at the time of the ingestion, which many hospices still do. But overall, let me correct, if I may, this view that hospices somehow are in this tense oppositional feeling with medical aid and dying. It's an old view. It's understandable. I get it as to why it started, which is that, don't forget that hospices had their own uphill battle to become accepted and known. Go back 50 years, hardly anybody was getting hospice care. Hospices were that place where you go on the day of your death to be helped to die, right? And they fought for their reputation to the point now where they get 40 to 50%, I think is the data. Tracey, you might have better data than me. I think about 40 to 50% of people in this country die in hospice care. That was an uphill battle, and they were very afraid of ruining their reputation by becoming affiliated with medical aid and dying. Okay, I get that. That was really a risk, but they fought that battle. It came up, and then when medical aid and dying came, it made them uncomfortable that they were going to lose their reputation again and be the place where patients go to die. And so hospices were hesitant. But when patients started, here's what happened. Patients started asking for medical aid and dying. So there was a groundswell from their patients, and hospices started saying that, you know what, it's okay. The sky didn't fall by helping a patient to die at the end of their life. Good medical care continued, good palliative care continued, and the patient got the death that they wished, which in the end is in the heart of every hospice worker. So gradually hospices come along, and I just see this as the best collegial, here's a bad quote that the enemies will quote me for all the time. If it weren't for hospice care, medical aid and dying would be immoral, and we shouldn't be allowed to do it. Because if I want to know, and I do, that patients who come to me asking for medications to die, I want to know that they've gotten really, really good end-of-life care. because it's unjust and unethical to offer medical aid and dying to people who are getting bad medical care. And so how do I know that they're getting good medical care is because 98% of the patients in my practice were in hospice when I got them, or have been put in hospice since, or encouraged to be in hospice. And so without hospice, I would quit. I could not offer ethical medical aid in dying if not for my colleagues in hospice. And so thank them for that. And we all know that, and we all hold each other's hands, and we dance and sing Kumbaya together.
And I think what I would say to that, Sarah, is, medical aid in dying is just one point in time. And many patients who go through this process and obtain the medication decide not to ingest it. They want it for a security blanket. They want to have that power and control at the end of their life. But hospice care can be a much longer process. They're engaged with these patients. And frankly, they have more resources, as they should, than medical aid in dying, which is just one point in time. So they have social workers and chaplains and nurses and aides and all sorts of people who are engaged in really helping these families through this sort of dying process. And we really, I don't think, can exist without the collaboration and the support of hospices. Many times, I hear from, some people who don't work in hospice care, like, this family is panicking if they're not on hospice and the patient is dying. And I have to remind them, well, this person has never died before. So this is a new experience for them. And the family may not have experience because, modern medicine, right? People are dying in hospitals and other settings different than maybe they were a half century ago, where maybe people were dying at home and people experienced and understood the dying process. So this is where hospice is just really invaluable for these patients. And I don't think we can unlink ourselves.
Thank you, Tracey.
Thank you. And so turning to communities with disabilities, specifically physical disabilities. Lonny, I'm aware that there's a new lawsuit being explored in California about, the self-administration criteria for aid in dying in California specifically. So I'm wondering what barriers to aid in dying care in this community of people with physical disabilities, what barriers persist, and can you elaborate a bit more on that, please?
Yeah, absolutely. It's a privilege to talk about that. Tracey, if I forget at the end of when I present that, I'm going to ask you a question now. Don't answer it yet, but is I see a lot of parallels between the disability community, right? I'm going to call it a community. It's not quite monolithic, but between disability community and the community of disabled people and African American community. And I really see those parallels very strongly, but I'm going to remind me if I forget to ask you that question at the end. Let me just put up, to help me with one thing, I'm going to share my screen again and put up one more slide just to give you some feeling as I'm talking. Is my screen being shared yet? No, it's not. There it is. Okay, let's just put up this one slide here and play from current slide. Okay. In my practice, roughly about, in my practice, actually about 15 to 20% of all of the patients requesting medical aid in dying are ALS patients. In the country, that turns out to be, if you look at all the different states, about 10%, invariably the surveys will show about 10% of all aid in dying patients, people who take the medications to die, are ALS patients. Realize that ALS patients are a tiny, tiny fraction of the population that dies every year. And so 10% means that there's something about ALS, because their usage of aid in dying, or as Sandy Morris, the co-plaintiff in this lawsuit we're having, said, medical aid in dying was designed for ALS patients. because of the way we die, usually by suffocation. We are a type of illness that is that are high users of medical aid in dying. So here's how the laws have played out and how I've had to play this out with so many of my patients. An ALS patient, and when I say ALS, by the way, I'm going to throw in also as synonyms, multiple sclerosis, Parkinson's disease. There are neurologic diseases, and I can name all the initials, MSA, PSA, all sorts of things. And PSP, I'm sorry. And so for those patients, there's a problem, which is that the law requires, and you'll see this in the upper left, that the patients self-administer the medications. These are the safeguards that are sometimes obstacles that we've brought up, but the law requires that the patient, as a safeguard, has to be the final actor, that the patient has to actually take the medication, swallow them, push a plunger on a syringe for a feeding tube, or when there's a rectal catheter, the patient has to, and here's the words, make an affirmative, conscious, and physical act of administering and ingesting the aid in dying drug to bring about their own death. That is felt to be a safeguard from somebody else actually making them die. I get it. It was important for the law. But then they added one very unusual thing that doesn't exist in any other law that involves disabled people. And you'll see at the bottom that that a person who is present can prepare the aid in dying drug. They can do all sorts of things as long as that person, someone other than the patient, does not assist. Whoops, I just moved my slides. Come back. There you are. As long as the person does not assist the qualified person in ingesting the aid in dying drug. So look at this thought of assist. Everybody with a significant disability has the right to assistance according to the Americans with Disability Act to have equal access to health care, whether it's a wheelchair ramp or a wheelchair, or a blind interpreter or a blind seeing eye dog. The right to assistance is inherent in the now totally and thoroughly accepted Americans with Disabilities Act, the ADA. And yet, uniquely, the End of Life Option Act, denies the person at the last moment of their life the right to assistance. It says right there, the person does not assist the qualified person in ingesting the aid in dying drug. And so my ALS patients, and Parkinson's and MS and all that, if they lose the ability for their hand strength or they lose swallowing ability, they are now excluded from a medical procedure, medical aid in dying, that people with other illnesses who are not disabled or more able-bodied people, they have the right to medical aid in dying, and the patients with disabilities like ALS lose that right unless they take the medications earlier on than they would like to, while they still have the physical ability to push that plunger or swallow the medicines. To my mind, I have thought since I started this practice and realized something like 1 out of every 5 patients in my practice are ALS patients, that this is highly discriminatory. I go through something with my ALS patients that I go through with none of my other patients, which is figuring out how we can get them to get these medicines into their body. And it's not that I don't believe in self-administration. Let's be really, really clear about this. We are not questioning self-administration. The affirmative, conscious, physical act goes along. An affirmative, that's meaning they consent. They nod their head or they speak their consent. Conscious, well, they're conscious of what they're doing, and they can make a physical act, such as they can put their hand on the plunger of that syringe or start to drink the medications. That's a physical act. They can even blink their eyes in assent. That's a physical act. But we must be allowed, and that's why I have this picture up here. There is a picture of a patient with a feeding tube with ALS who is wanting to push that plunger and just has about enough strength to push in maybe a quarter of the medicines. And I am not allowed to assist that patient by helping push on that plunger, because that is now felony murder. Because I have been forbidden by this law, unique to this law, where it tells you, ignore the ADA. You cannot assist in a medical procedure for a patient who needs assistance because of a disability. So we have seen for a long time this contradiction, and I will tell you that in my own practice, I have broken the law. but you don't know which way, because I have to break one of these laws. I'm either going to break the End of Life Option Act, right, by assisting. If I do put my hand on that plunger, I have violated the End of Life Option Act. And if I don't put my hand on that plunger, I have violated the Americans with Disabilities Act. So we as practitioners have been put in the position where we have to violate one of those acts or the other. And so the courts are just going to have to figure this out. There are two laws in opposition. The courts are going to have to figure it out. We were hoping that SB 380, the modification of the California law, would take this on. It did not. And so we decided to go to court, and we are suing the state of California to allow for assistance. We're not saying get rid of self-administration. We're fine with that. We are saying that if the patient needs assistance, as they do in getting dressed, look at Sandy Morris, the plaintiff in this case. She needs assistance in scratching her nose. She needs assistance in getting dressed and getting fed, and she needs assistance in preparing the aid and dying medications. But at that moment, that crucial moment of wanting, when she's ready and it's enough and she's ready to end her life, we pull back and we won't assist her. How very cruel and discriminating. And so that's what the lawsuit is about. It is now in full process, and stay tuned. We'll let you know how it goes. Get rid of my slide. Stop sharing. So, Tracey, to go back to this now, we have a whole disability, people with disabilities eventually come to the point where they're dying. People without disabilities eventually come to the point where they're dying. We all do that, right? But yet I see, I think, a tremendous parallel between how we look at disability, people with disabilities, and how we also look at African Americans. And maybe I've overstated the case, but I wanted to ask you that question for a long time.
I don't think overstated at all, Lonny. And I think I have one word, paternalism. And, I'm guilty of this working in healthcare as well. But I think patients, and we'll leave out for the moment patients with developmental disabilities. We'll talk about physical disabilities, patients who need assistance, as you just eloquently described, who need physical assistance. We don't listen to them in the same way that we don't listen to communities of color. And I would argue that people with disabilities experience discrimination in spite of laws, in the same way that people of color experience discrimination in our healthcare system in spite of laws saying these things shouldn't happen. So I think the parallels are very clear. And I think that the disability community, if we want to refer to it as a community, has many of the same challenges that communities of color face when it comes to medical aid and dying. Do people with disabilities have equal access to health care as those of us who are able-bodied, who don't need that assistance? I'd say probably not, even though the politically correct answer is, of course they do. And we have all of these safeguards in place, just like we have in place for communities of color. But we know the reality, or the patient's reality, or the patient's experience says that's not true. So I would think that patients in the disability community probably have even, I would argue, maybe more challenges than communities of color accessing medical aid and dying, because of that anxiety, I think, of healthcare providers thinking, well, we don't want to be seen as not being respectful and inclusive of disability communities, and we don't want to be seen as encouraging these patients to hasten their death because of their disability. And I think in many ways they have even more of an uphill battle than communities of color. I think, of course, there are some amazing advocates, disability advocates in the community, but I think they're likely divided when it comes to medical aid and dying in some ways, because they too have all of these other challenges in healthcare. And so how could I be an advocate for medical aid and dying when my, you know, community is not able to access great healthcare in other ways? So I think it's the same argument that communities of color have. And I'm not sure how we can overcome those challenges, except to say that, again, the challenge, the problem is ours to solve, not those communities, right? I think, you know, as healthcare providers, we have the power to change our system and to change the culture in which we work, to change healthcare. And so just like our colleagues in hospice and palliative care had that uphill battle, and they haven't made it to the mountaintop, by the way, they are still struggling with acceptance, but they've made great strides in the last, you know, half a century. I think we have that hill. We need to climb that same hill, and hopefully they'll lend us a hand and help us up, because it is the same or a similar challenge for acceptance and belief and acknowledgement, because of all of the other barriers that exist before you get to that point.
Yeah, yeah, thank you. I think that's really well put. We live in a society, and I'm going to use the word that comes up to me in thinking about this is devalued. And if we look at the healthcare system, or even society at large, there is a predominance of white, affluent, because they get paid in the healthcare system. We are white, we're affluent, we sort of live in our own communities. There's isolation and separation. And so when somebody, I think, sees a poor African American older man and is starting to think about who gets the ventilator, or as we saw in the hurricane in Katrina, in the hospitals that were never up to par, and they were euthanizing people because they didn't have the facilities during Katrina. And I think that idea was, we don't see the value of those people's lives because they're not like us. And I'm using the us in a fairly specific way now. With the us is the majority of the healthcare system is more affluent, more white than the general population. And so we don't see people who look like us, and we devalue their lives. And that certainly, I think, is why people who are Black get fewer coronary artery bypasses and angioplasties when they come to the emergency room with the same symptoms. You know, it's a hidden but certainly present bias that we have to acknowledge, because the data backs it up. In the same way, I've talked to my people who are disabled, friends who are disabled, and they will tell me time after time, they show up in their somewhat distorted bodies and their weakened respiratory systems, and they show up and they've got a bad cold and they're worried, and the doctor says, do you really want antibiotics? Because they say, you know, look at your life. I mean, do you really want antibiotics? And do you want to be put on a ventilator? It'll be so hard to get you off that ventilator. And they have a common pneumonia. I mean, this is, and I hear this time and time again, where patients who are disabled are recommended to hospice instead of to aggressive medical care, because we look at their bodies and say, that's not a very valuable life. Kay Hudson at the beginning of this talk said that. Repeatedly, she said, they did not see the value in Stevie's life. But we, every day for 3 years, taking care of him at home on the ventilator, loved him, and we lived the value of his life every day. Who are you to come in here and tell me that he shouldn't be alive anymore? And so this question of devaluation of other, right? If we live in a predominantly white and affluent medical community, we're going to devalue the lives of others, and therefore they're not going to get as good care. And I do think, I think you're right, and that there's a commonality between the communities of anybody who is devalued. They have common issues that we all have to deal with, and they don't have to fix the problem of lack of access to medical aid and dying. We have to fix the problem of the fact that they don't trust us for fairly valid reasons. That's on us.
Agreed. And we don't trust them either because we know better. We know what decisions should be made. So,
Yeah.
uh,
Yeah.
yeah, definitely agree with you. And, it starts with all of our educations in graduate school and medical school and nursing school, whatever discipline you are, right? How much time is uh, given or to address these issues, how much education are medical students given about working and caring for patients with physical disabilities, how much education is given about caring for communities of color, and how many medical students and medical professionals still believe many myths that people in the community believe, but they're not medical professionals. Oh, Black people have a higher pain tolerance. Oh, their skin is thicker, and so they don't feel pain as much, and so they don't need as much pain medication or pain control. Well, you
Or
just
they have a high rate of addiction, so we shouldn't be giving them opiates.
correct. So, and all of our opportunities to do education within our systems. And so I think that is my theme of today, is that the problem is not with the patients, the problem is us and our system. And we have to acknowledge it and take responsibility for it and figure out then if the problem is ours, then we have to figure out how are we going to fix it.
Thank you. And just jumping in briefly to some audience questions, Thalia wrote in the chat, what about diversifying medical staff? How does, as she puts it, the shocking lack of diversity in staff play out? What are your thoughts?
Well, there is a shocking lack of diversity, and I am not sure unless we have some, student loan forgiveness for medical students and other people. I'm not exactly sure how that's going to be fixed, except we've seen it in medicine, right? Medicine used to be predominantly men and women weren't included. And now I think medical schools, I think we might be over the 50% mark for new medical students coming in are more than 50% women. And I think we've seen changes in medical education because more women are entering the field of medicine, meaning physicians, right? So I think change is slow. It's like cold molasses. My grandma would say, being a Southerner, it's like cold molasses, but it's moving and we're getting there. But I think um, we all, and I say we because we work within the system, have to think about when we are forming our teams, are we looking for that diversity? I think human nature is that we want to hire people who are like us. And I don't necessarily mean race, but people who think like us, people who believe the way we believe. Would we hire someone who really, from a cultural perspective, is opposed to medical aid in dying? Would we hire them to be on our MAID team? Probably not. We'd probably screen out for that. But I would say it's valuable to maybe have that diversity of opinions and diversity of, in terms of race and ethnicity and genders on our teams to keep us honest. Because if everyone thinks like us and everyone looks like us, then why should we change? Then we're right. It's the other who is wrong and they need to change.
Tracey, focus this in with me for a second. I have no data about this, so I'm sort of closing my eyes and using my imagination of all the hospices I've interacted with in the last number of years and how white they are. The hospice staff I'm talking about. And how unusual, it's improving, like anything else, it's not a monolith, but I'm pretty impressed that we go into communities and those communities never get to see somebody who's from their community who's their hospice nurse or social worker, and not never. I tend to over exaggerate, but my sense is that in end of life care, as in many places, but it seems even wider than other parts of practice. Maybe because we ourselves are a low prestige end of the spectrum in medicine. We just take care of dying people, they don't count. But I wonder if you have the same feeling. My gut reaction says, having participated in emergency medicine and certainly refugee and immigrant care and other aspects of medicine, that in the end of life field, we seem to be a lot wider, not more affluent, that's for sure, but at least a lot wider. What's your sense?
I would have the same sense, Lonnie, but the question is, who is going to challenge us on that? It's like the Oscars. We're so white. Remember Oscars so white movement, right? For years until someone decided, okay, we're going to call ourselves out for the lack of diversity. So I think that we have a responsibility to call ourselves out for the lack of diversity, and really challenging ourselves to be open to having people on our teams who maybe aren't like us. And when I say who aren't like us, who maybe really just are completely opposed to medical aid in dying, but they are interested in maybe getting involved in end of life work, for example, because they would challenge us in a way that we're never challenged on a daily basis because we are of like minds, and it's just much easier to go about your day, right? Rather than having this person who's challenging you and asking questions in a way that we're not accustomed to and that maybe we don't appreciate. Because I think in some ways, if we had that diversity amongst our team, we could then better understand and appreciate and respect the diversity amongst our patients. And patients are really very generous, I think, allowing all of us who are not from their communities to come in and actually trusting us to do a good job, to see their homes, to, drink their water, to sit on their couches, to talk to their family, to hear their stories. They are in a very vulnerable place, and they open themselves up to us with their vulnerability. And I question, do we do the same? I don't think we do.
Deep breath.
Tying into an additional barrier to healthcare access, Kathy is wondering, what about discrimination that occurs because of lack of insurance?
Yeah, I talked about that a little bit earlier about uninsured patients and underinsured patients. And the reality is, do we even know who they are? Because if you're uninsured, and see, now we're getting back to the access issue, and this is why the access to healthcare issue is our problem. If patients don't have insurance, how would they even know they have a terminal illness? I mean, where are they going to get that diagnosis if they're not receiving regular health care to even be aware? Maybe at the very end, when they're so ill and their family takes them to an emergency room and they get a devastating diagnosis, and then what hospice is going to care for them, because hospice, and not always, but many times, is a business. And so they want insurance because they've got to pay their staff. And so then, is that patient going to get hospice services? And if not, how would the patient even know about MAID? I would argue it almost will never happen. It's almost, I'll never say impossible, but it's almost an impossible situation therein. So I think it's very difficult. So that's the uninsured, but sort of same challenges with the underinsured. They're probably fighting so much just to get that basic health care, and maybe trying not to use the system too much because either they've got one of these high deductible plans where they can't afford to just have routine, go to the physician routinely. They sort of wait until things are really bad because I can't pay this $3,000 deductible that I have. Or patients who have Medicaid or Medi-Cal, I would consider to be underinsured, and maybe would worry about, would Medicaid cover something like medical aid in dying? Would Medicaid or Medi-Cal cover hospice care? And I think the answer to hospice care is yes. I think the answer to medical aid in dying is maybe it depends on where you are, and what advocates you have. But if people, I would, I guess, challenge us to think people who are uninsured or underinsured really have to pick their battles, because I have to battle today. Am I going to be able to pay my rent or my mortgage, or keep the lights on or the heat on and food in the refrigerator? And, we have, everything's more expensive now. Can I afford toilet paper? When COVID hit, there's a run on toilet paper and now it's $10 for a 4-pack or whatever. People who are in those life and death battles on a daily basis just to live and just to survive, this is really a luxury, I think. I think patients would see it. I don't know that I feel it's a luxury, but I think in their lives and the things they have to fight for, these services would be a luxury, and I don't know that they would fight to get access to them if it's not offered and if it's not readily available and they're not educated about it, and have advocates outside of their home to do the fighting for them.
Let me piggyback onto that, if I may. All aid and dying patients are underinsured or uninsured. So I'll put that out there. Yes, there is the underinsured and uninsured patients in general for all of their care, but you can be the best insured patient, including Medicare and including your private insurances and all that, and you're not insured for medical aid and dying, because Medicare doesn't allow payments for medical aid and dying. So you can be in hospice, right? And the hospice may provide all sorts of great things and even be the consulting physician, but when they send you out for an outside of hospice aid and dying prescribing physician, because the hospice, that particular hospice, let's say, doesn't, which is common, well, then that physician has no way to bill, because Medicare doesn't cover Medicare. It's illegal to bill Medicare for aid and dying. Medicaid, if you happen to be that poor enough, only covers medicines, and even that is pragmatically so hard to access because they don't cover compounded medicines, and that's what we use. So in essence, all aid and dying patients are uninsured completely for that component of their medical care, and it is a component of their medical care, every one of them. Given that, it's no great puzzle that white affluent people access medical aid and dying more commonly than other communities, because they all pay out of pocket. And it's a dilemma even when we talk about access to medical aid and dying, that implies that there will be attending physicians to write the prescriptions. And since we can't bill in our existing systems for medical aid and dying, and it's so much work, many doctors have told me, I can't do it. It's too much work. I've got a busy practice and I don't get paid for it. Or I get paid like an $88 office visit for hours and hours of care, including going to the death. And so the obstacle of insurance is somewhat unique. It's global in healthcare, as you said, Tracey, but it's also very unique to aid and dying practice because nobody is insured. End of story. It's such a rare entity when I hear somebody that got any insurance reimbursement. So it's an obstacle for the doctors to participate. It's an obstacle for the patients to participate. And we are basically in the dark ages of insurance until that changes, and that's got to be a major policy push because it increases discrimination, it increases privilege, and we wind up working with affluent white people who usually pay $3,000 out of pockets, and then you kick in $850 for the medicine, and you wonder why poor people can't do it.
Correct. And maybe this, my earlier or my opening comments were probably a bit provocative for some in the audience, but, that's sort of where my comments came from, is that, this movement, this healthcare, it's political, it's economic, and it's race-based. And this is something that perhaps the movement, we'll say the political movement for now, the advocacy movement, can really, I think, benefit these patients if, and I'll say they want to look beyond sort of what has been achieved so far. You know, I do see a lot of celebrating and happiness when these laws change, or when the laws are updated to benefit patients, and that's wonderful. And I'm not saying we should not be happy about those things, especially for people who want to avail themselves of this option. But there are many, many more battles, I think, to be fought, to diversify and to open their arms and their movement to the other, to the disability community, to Brown and Black communities, to the uninsured, to the underinsured, who cannot afford this option. So you're right about that, Lonnie.
Yeah. And Tracey, I was tremendously neglectful a moment ago in not mentioning that the exception to this, all aid and dying patients are uninsured, is Kaiser, where Kaiser has a full and active aid and dying program, and it's covered by your Kaiser plan. And it's unique in that it's probably the only system that does that. So thank you and congratulations. I think that in Kaiser, the use of, you know, the navigators, the whole thing, that's all part of your Kaiser plan, including medical aid and dying care. I don't know if it includes the medicines. Do you?
It does.
Yes.
Well, it's complicated. So there are some patients who have employer sponsored plans, of course, where they have opted out, and that does make it more complicated for those patients. But, you know, this is, I think, the advantage of being a system. You can sort of do whatever you want in a way. I'm oversimplifying, and not worry about the reimbursement, but this is not the experience, I think, of most patients in our country, and most patients, you know, who want to access this option. So I do think there is still a lot of work to be done by the advocacy community.
Yeah. And I'm sorry, it's just that I misspoke. If I think of Kaiser as an insurance policy rather than a healthcare system, which it also is, then there is a huge insurance system that covers medical aid and dying. Thank you.
But we're limited, you know. California, fortunately or unfortunately, is not, the rest of the country is not like us.
Sure.
So thank you both. And I know we're nearing the end of our time today. Unfortunately, this has been a rousing almost 2 hours of incredible scope and depth. And so thank you so much to both of you. Just one last question. You know, from physically disabled individuals to Black and Brown communities, and, you know, diverse communities within, how do we invite these individuals to the conversation to really begin to open up and experience full access to aid in dying? I know we've covered the pitfalls today, the potential as well, but, you know, exploring in concluding remarks, how we might foster this in a better sense for patients in California in particular, and also for the rest of the U.S. in general.
Well, I think one thing I would say, and that's a great question, Sarah, I think that we have started to figure it out in other areas of medicine, right? And so we can learn from what our colleagues have done in other areas of medicine. So thinking about blood pressure control, the way we approach patients, educate them, encourage them to have lower blood pressure is different for African American patients versus white patients versus Asian patients, right? Same thing for smoking cessation, same thing for diabetes, blood sugar control. We have figured out we can't use a one size fits all approach in other areas of medicine. And so I think my argument would be the same with medical aid and dying. I think we have started this process, basically saying this is what it is, A to Z, and we don't change our approaches. to suit the patient. We just say, well, you know, these are the 17 steps you have to make, and we don't make accommodations for who you are, being a person who's disabled or a person of color. And we need to start doing that, of course, within the confines of the law. And I understand that, but I think that is our challenge. As healthcare providers and people who work in medical aid and dying, is to start changing our approaches and learn from other areas of healthcare where they have figured it out for certain illnesses and diseases. We can do the same thing.
I think this question of Tracey likes to use the metaphor of how do we invite them to the party? And I think in this case, if we're talking about the medical aid and dying party, which is also an interesting visualization for me. But you know, how do we invite people to the party? And the answer is, I think, is you become very, very clear that you're not the only party in town. And you don't have the best party either. You have a party that some people might want to go to and some people don't want to go to. Some people want to go to the hospice and minimal pain control party, and there's all these choices. And I think we have to really realize that again, this is the bigger theme we keep on going to, right? We in the medical aid and dying community are part of the bigger community of medicine. And I think that's becoming more and more as time goes on, as we become more respected. And this is what I think the Academy, to put in my usual plug, is really arguing for, is we want to be part of the medical community. We want to have our own academy. We want to have best practices. We want to make sure it's done well. We want to do good pharmacology and provide good care and do everything the rest of the medical community does. And we're susceptible to the same problems as the medical community, which is we're elitist and paternalistic. And so we have to work within the parameters of the larger community while accepting that we have some of our own unique issues that are different than the regular medical community. And when we come across with this attitude, even linguistically, of the right to, you know, look at our language, the right to die. Everybody has a right to die. Where did we come across that we own the right to die? Or the term death with dignity, which says that aid and dying is death with dignity, therefore your death, if it doesn't do aid and dying, maybe not so dignified. So as long as we keep on thinking we have the best party in town, people might say, well, I don't like your party, I'm going to go to another party, or you're being arrogant and I don't like you anyways. I think we have messaging problems about how this is the good death. This is the death with dignity and all that. And we have to open that up so that when a patient contacts me and says, I want a death with dignity, I'll say, well, you got a lot of choices for that. I will not just say, well, I understand what you mean. You mean medical aid and dying. I will say, tell me about your pain control. And so if we're not willing to be part of the bigger picture and to look at Stevie and Kay, and say, what can we do to help you in your healthcare? Because you don't trust me, I know that. And I see that you've got like a leaky, I'm not sure you've got the best respiratory attachment on your tracheotomy tube. Can I get you a better respiratory therapist? And I just don't, you know, and a lot of aid and dying doctors say, well, that's not my job. You know what? It is. Your job is to make sure that people are getting really good care and they're going to die as well as possible. Whether they take your aid and dying medications or not is irrelevant. And if we don't amplify our focus to be part of the end of life care system in general, and do a really good job and know that we're only one part of it, and become patient advocates in that system, then they're not going to come to our party because our party's too narrow. We're only playing one song, you know, and if you only play one song and they can only dance one way, it's not a very good party. And so in that sense, I think we have to have a bigger and better party, and we have to open our doors to more people. And if somebody comes to the party and says, I don't like that song, we can't say, well, that's the only song we have. We say, let's get a better DJ next time. And really try and say, well, maybe the problem with the party isn't the music, maybe it's the booze. And so how can we get better booze? really not just keep on this sort of like narrow focus. I know doctors who only consider themselves to be aid in dying, and they get called up about the aid in dying. They do 2 evaluations, they write the prescription, and then that's their entire involvement with the patient. And on a personal and as the chair of the academy position, I have to tell you, I think that's bad medicine. Right? You've got to be more involved in the care of your patient. They are your patients, and you have to become their advocate. You have to make the party better, and not just say that we have the only party in town. If you don't want this party, well, go away. So sorry to steal your metaphor, Tracey, but I like it.
Thank you, Lonnie, and thank you, Tracey. This has been an incredible 2 hours, and I'm just so grateful to both of you for joining us today and honoring the completed life stage with your presence. And also to our audience, thank you so much for tuning in, submitting your incredible questions and comments into the chat. I entered a few emails, one for Lonnie at the Academy, and Tracey as well. If you would like to follow up with direct questions to both of them, as always, feel free to reach out to us at the Completed Life Initiative via email, info@completedlife.org, and check out our website, completedlife.org. This concludes session 3 of our 2nd annual Completed Life Fall Conference. And we have yet one more session to take us away for the epic conclusion of this 4-part series on medical aid in dying, within the question, what does it mean to live a completed life? We hope you can return and join us again for session 4 coming up on Tuesday, November 16th, looking at the global significance of the Right to Die movement, and evaluating the question, what does it mean to live a completed life, from more of a global lens. So we look forward to welcoming you back for that session. And as always, the recording of this session and others past will become available shortly. So please look forward to that, and feel free to share it widely and broadly with your connections. So with deep appreciation, and many, many thanks to you, Lonnie, and to you, Tracey, and again to you in the audience. Thank you again for joining us, and we'll look forward to seeing you next time.
Thank you, Sarah.
Thank you, everybody, for being here. And Sarah, thanks for your great interest in moderation.
Thank you.
Kept us honest.
Be well.
All right. Bye.
Bye-bye.